So that year we were having a party, our annual holiday party was at the shoe repair shop. It was like an 80s party, I think. We had the massive monkeys there. It was like a b-boy group. I definitely looked cool. I was peaking on that day. And Jenna, Dr. Cha, was kind enough to come to that party, and I told her, I was like, this is your interview. I want to see how you socialize. And she socializes like a rock star. She's amazing. At that time, she decided to go back to practice in California, which she did until 2020.
2021.
2021, at which time we were really pleased to offer her a position at Pugetsound Perio, and she's been with us ever since. Dr. Cha graduated from the University of Pacific. She's one of those kids that was able to get in as a teenager and graduate almost as a teenager, and then finished her perio residency at Oregon Health Sciences University. So board certified, former valedictorian. If I had a little sister, I wish it was her. Please welcome Dr. Jenna Cha.
Thank you. Wow, thank you, Dr. King, for the nice introduction. For those of you that don't know me, my name is Jenna Cha. I'm one of the periodontists at Pugetsound Perio. It's really been an honor to have joined this practice and be part of this community. So thank you for letting me finally speak at our own study club. I joined kind of in the middle of COVID, so haven't been able to do this, but yeah, I really appreciate the opportunity. So without further ado, I'm gonna go ahead and start the presentation so I don't want everybody to get home too late. So outside work, I am a boy mom, and this is my son, Jordy. This is him at 100 days old. It's a Korean tradition thing we do when they have survived 100 days. We do a little celebration. And now he's a full toddler. He's about 19 months, and that was actually us right before we went to the PSB Luau this year. Jordy didn't join us, but we were able to get a quick photo with him. And yeah, now he's a full-on toddler, and it's just been really fun, but also been a little challenging to keep him entertained. So if any of you guys have any parenting advice, please share your secrets.
Give him a little brother or sister.
Well, we have one cooking.
That's right.
So as today's presentation, we're going to be talking about peri-implant and periodontal soft tissue management. I'm going to be talking about utilization of custom healing abutment and provisionals, talking about pharyngeal graft and connective tissue graft around implants and dentition. So custom healing abutments are developed to capture patients' existing natural appearance of soft tissue, a lot of times used right after extractions and immediate implants. They can also be used during delayed implant placements, and obviously they are used to preserve that natural emergence profile and really better the aesthetic outcome. And well-made custom healing abutments should have this nice concavity to that contour. And having that nice concavity will add more thickness to the proximal sites, which help preserve papilla volume. And by doing so, it also leads to longer connective tissue attachment and also being able to maintain nice volume of keratinized mucosa. And we do all of this to make sure that the restoration process is smoother and faster for our referring docs and the patient. And custom healing abutments are made in such a way we try to do minimally traumatic extractions. And when we have an immediate implant placed, we go ahead and place our titanium temp abutment. And we're gonna go ahead and put a little flowable around it and go ahead and cure that. We take it out of the mouth and we go ahead and start adding contour to the implant platform. And you want to make sure this is nicely polished and try to get that nice concavity contour to it. And delivering the custom healing abutment, and the procedure is really minimally invasive and simple, but it really achieves the best aesthetic outcome that it can come out of. This is one of the cases that I was able to use both custom healing abutments and the provisional to train patient soft tissue. Patient came in with failing anterior bridge, and he was a lawyer. And he didn't care too much about the aesthetics, but he definitely wanted to get a better smile line. And he wanted to make sure that the healing time isn't too long, because he would have to wear removable appliance during his core cases and stuff like that. So when we took a CBCT scan, we were happy to find out that he was going to be a good immediate implant candidate. We're planning to do implants at both site 7 and 10. So we were able to take the teeth out and place implants immediately, and the scan bodies were placed, custom healing abutments were placed. So we go ahead and send this data to our lab, and the lab will have a provisional fabricated. And at the time of uncovering, about 4 months, I go ahead and remove the custom healing abutments. And a lot of times at this time, it's, the patient's actually totally ready to go back to the referring doc for final restoration. But in this case, the restorative doc and I had decided that it would be better to have provisional put in place before sending the patient back to him. And this is how the tissue contour looks like after the custom healing abutments are removed. You can see there's a nice volume, and we have a really natural emergence profile preserved. And this is time of provisional delivery, and as you can see, the shade is very, very off. But what do we know? We're just periodontists. And we do this on purpose so that our referring docs look like superstars in front of our patients. And again, this was at initial presentation and to provisional delivery. There was very minimal amount of suturing. We never had to flap the case, and patient was surprisingly happy with the outcome, even though I didn't make any comments about the shade, but I think he left happy. And when we sent the patient back to our referring doc, this was a 1-year post-restoration delivery. I always like to follow my anterior cases, and the restoration was done by Dr. Korsmo. And you can really appreciate that he found much better shade than me. So I'm really glad that the patient is in good hands. And yeah, again, with the final prosthesis, you can see that the emergence profile of all of these implants and the pontics have been really preserved nicely. And in terms of soft tissue augmentation procedures, so why is having keratinized tissue around implants so important? It's because they help a lot with plaque control. There's numerous literature and research that support that plaque control is much better when there's more keratinized tissue remaining. And with inadequate width of keratinized tissue, we just have a lot more complications. There's a lot more biofilm accumulation, which leads to peri-implant mucositis and peri-implantitis. Patients have a lot more inflammation, recession, which ultimately leads to bone loss and patient discomfort. And this is because teeth and implants have different anatomy when it comes to soft tissue attachment. With teeth, with dentition, we have these Sharpie's fibers that insert perpendicular into the cementum that creates a very strong and resilient attachment. Whereas with implants, we only have really few collagen fibers that go parallel to the implant surface. And the seal is not very strong. So when there is inflammation, when there's a lack of keratinized tissue, we lose that first line of defense. And the peri-implant soft tissue mucosa tends to be a lot more vulnerable. So in terms of having long-term success outcome, making sure that we can do everything we can to preserve that tissue and maintain that health is very, very critical. And the best way to gain keratinized tissue is by utilizing free gingival graft. Now, as most of you know, free gingival graft is harvested from the very outside epithelium of the palatal tissue. And a lot of times the aesthetic outcome is not as great as connective tissue graft. A lot of times they kind of look like this little tire patch. But we love having this keratinized tissue around implants because at the end of the day, aesthetics are important, but it's really about having that nice band of protection against the peri-implant mucosa. And free gingival graft can be utilized in many different ways. in terms of improving the peri-implant soft tissue. Now this case shows when it was used during stage 2 uncovery procedure. Now there had been 2 implants placed and simultaneous bone graft was completed. And when we are doing that significant ridge augmentation, we get a primary closure and the tissue tends to creep up and the mucogingival junction ends up in a lot of times at the height of the crest. And when the final restorations are placed, you can imagine on the buccal surface, this tissue is really not attached. So in order to prepare for that, what we go ahead and do is go ahead and finish our uncovery. We go ahead and place our free-gingival graft around the healing abutments. And here you can appreciate that little thin, about 2 millimeters of keratinized tissue was pushed to the lingual, so we still have good amount of KT on the lingual and a lot more on the buccal. And this heals in about 3 weeks, but we prefer to let the tissue mature for about 6 weeks or so before a patient returns to the referring doc for final restoration. And this is another case that I actually did back in residency. In this case, what we ended up doing was place the implant, we augmented the site first, and implant hasn't been placed yet, but we noted that there was some mucogingival defect on tooth number 20, and we wanted to address that before placing the implant. And so over here, what you'll also appreciate is the mucogingival junction being at the line of the crest. So we go ahead and finish our free gingival graft, and you can see that we were able to gain some root coverage on tooth number 29 and gained a lot of that keratinized tissue at the edentulous site. So we go ahead and place the implant, and I see the patient in about a year. And since this was a school and we get to do everything we want, patient wanted a gold implant crown, so that's what she got. And it was really cool to follow this case from beginning of residency to end of the residency, and really surprised to see and document that this is a really cool case of what we call creeping attachment. So you can appreciate that at the time of free gingival graft healing, we still had some root that was showing off. And at the end of about a year after the restoration was completed, when I saw her, this tissue actually crept up and we were able to get a full root exposure covered. And you can really appreciate the tissue difference from prior to free gingival graft to post. And this is probably one of the most common ways that I do my stage 2 procedure. And just wanted to show that soft tissue improvement can also be done without tissue graft by just maneuvering a patient's own. So in this case, at the time of stage 2, what we do is go ahead and make a lingualized or palatalized incision. And I like to keep my papilla, so make just the 2 small vertical incisions, and I'm going to go palatal to where that implant was placed. So we go ahead and open that flap, place my healing abutment, and now that flap will be apically positioned, and we go ahead and suture. This is a really simple, easy way to preserve the tissue instead of just using a tissue punch to remove that healthy, beautiful keratinized tissue. And this is another case that I did in residency, and we just felt a little fancy, so we ended up doing a little ridge split, but it was just an immediate extraction on tooth number 6, and we ended up placing these 3 implants. We did a significant bone grafting, did a periosteal release, got a really nice primary closure. And like we mentioned previously, what that does is now move mucogingival junction all the way to the palatal surface. And this is where the implants are. So now at the time of stage 2, before putting the patient to a soft tissue grafting procedure, what we wanted to do was try to maneuver the tissue and see if we can avoid doing a soft tissue graft. So what I ended up doing was make that incision much more palatal to where the implants are placed. And with that full thickness flap, if there's if there's a pretty good thickness of that connective tissue, you can kind of fillet that, and then that goes in between the implants. And this technique is really good at kind of creating that papilla between the implants, and can definitely be used in anterior cases or implants that are kind of adjacent to each other. And this is how it heals. You can see that that palatal keratinized tissue has now been moved apically, so we're able to gain some keratinized tissue here. We ended up doing another pharyngeal graft for that posterior implant, but we were able to avoid harvesting a super long pharyngeal graft just for this procedure. And pharyngeal graft can also be implant after implants are placed, and especially if they come back with some complications. Now this is implant number 30, and this is at the time of initial presentation. You can see the tissue looks a little cyanotic, very inflamed and swollen, and a little bit of suppuration there. And when I inherited the case, this is how the healing looked like. This LePip case was actually completed by our beloved Dr. Gretchen Stern, and the healing looked fantastic. The patient was ecstatic, and I was really ecstatic. Dr. Stern had already prepared the patient that there would be a lot of tissue shrinkage expected, and that she may need some soft tissue grafting afterwards. So when I saw the patient for the final eval and probed around this area, probing looked really good, but this tissue, there was no keratinized tissue, and it was not attached. So what we decided to do was do a pharyngeal graft around this existing implant crown, and this is how it heals. So again, it's not very pretty, but we were able to gain a really nice amount of keratinized tissue, and now this patient has a very good long-term outcome to maintain this implant. And again, this is another case that I had. A patient already had existing implants. She's actually had implants on 3 different quads, multiple implant bridges. And here you can kind of notice that these implants have been placed a lot more buccally. And this tissue was, again, not attached. There was no keratinized tissue remaining. And this prosthesis was cement retained, so we didn't want to modify, or we couldn't really modify the restoration. So what we wanted to do was improve the soft tissue. We go ahead and do a pharyngeal graft around those 2 existing implants. And this is at 3-month healing, looking pretty promising. And this is at about 1 year. So you can see that the implant threads are still exposed, but the tissue quality is much more robust, and it's now attached, and patient can brush here without having any pain. Now, with this exposed threads, if you want at this time, you can go in and do some implantoplasty around this, but the patient was able to clean this area really nicely. She didn't have any bleeding, suppuration, or issues, so I just left it as it is. But I have been following her for quite some time now. We've reviewed use of pharyngeal graft to increase the width of keratinized tissue around implants. And connective tissue grafts can now also be used to increase mucosal thickness around implants. And they're a lot of times used in aesthetic areas, but can also be used in posterior sites. And again, adding all of this extra volume ultimately leads to having that nice protection of tissue, which helps with preventing bone loss. So with this case, this is actually the previous patient that we just saw on her contralateral side. She's got another implant number 3, and then she's got these 2 implants posteriorly. And on number 3, she had minimal attached tissue, minimal attached keratinized tissue. So over here, we actually decided to do a connective tissue graft. And on the lower, this tissue, there was no keratinized tissue remaining, so we decided to do a long band of pharyngeal graft, ranging from implants all the way to that premolar. And then with the connective tissue graft, yeah, it's just a picture showing opening that flap and being able to really adapt that tissue nicely. We've got a nice closure there. And at 3 months, you can see that the tissue has fully covered those implant threads. And at 6 months, you can see frigingival graft is also maturing really nicely. And all of that unevenness you're seeing is the rugae from the roof. And this is about a year. So again, over here we've got little less keratinous tissue than the frigingival graft site, but all of that tissue is attached and very robust. So again, she's a trooper. She went through so many surgeries of gum grafts, but she's really happy with the way everything is looking and the way that she can clean everything. This case came back with a pretty significant horizontal roof fracture, and after minimally traumatic extraction, we're able to do an immediate placement. And I ended up placing bone graft, and underneath this flap, I added some connective tissue graft here to add that mucosal thickness. We had good palatal bone, but the buccal bone was on the thin side, so I wanted to make sure we add that nice thickness there. And in cases like this, once you have a good primary stability and have a good adjusted bite, that you're able to put a full contour provisional as well, and really have the patient heal with a good aesthetic outcome. In this case, I believe this patient was very young. He was a young firefighter, and he was finally ready to do something about site number 10. And he had a nice mustache, and he didn't really show his gum line too much, but you can see that his his tissue is very scalloped, and you will see all of his papilla when he's smiling fully. So I wanted to make sure that we do a really nice job to keep his nice papilla there. So when we took that CBCT scan, the bone was a little bit on the narrow side, and you can appreciate that there's an apical undercut of that tissue. And he was a firefighter, so kind of same thing with that lawyer patient. He didn't want to have to go without a tooth for a long time, and it was hard to kind of schedule his timing to do the procedure. So we wanted to get as much as we can done in one procedure. So what we did was plan this case guided. And as you can see from this angle, when the implant's placed at a restoratively driven position, we are going to show very thin or possibly a fenestration of that buccal surface. But the root is very short, so we're still going to get a good primary stability. So we went ahead and placed the implant, and this fenestration was expected, and it was there. And what we decided to do was graft this area, and we took a scan at the same time so we can have a provisional ready for him at the time of uncovery. And if you take a look at this picture, implant was placed quite subcrestally, and it's because we wanted to make sure that we see where that final gingival zenith was going to last. It was going to be end up, and when from that gingival zenith, you always want to make sure you place the implant deep enough, because if you place the implant too shallow, especially in an anterior case, their body's going to establish biologic width itself, and we're going to cause bone loss and tissue loss, and it's just not going to be a very good aesthetic outcome. So when in question, I think it's always better to go a little deeper. So that's why the implant was placed a little bit subcrestally here, and even though the buccal shelf was apical to the implant platform, we're going to do pretty significant grafting, and patient had good mesial distal bone here. And over here you can also see that when I did a full thickness flap, I still kept the papilla, so that way we don't lose any of that volume. So we go ahead and graft this site, and place a resorbable membrane and nicely secure that. We also threw in some connective tissue graft and go ahead and get a nice closure. And we place the healing abutment, shallow healing abutment, so he can still wear his S6 retainer. And in 4 months, he came back. This is at the time of uncovery. You can see that connective tissue graft added really nice volume there, and we have a lot of tissue to play with. So we go ahead and deliver our provisional. And this is time of 4 weeks after provisional delivery, and we're happy with how the tissue level and gingival zenith ended up. So we go ahead and send the patient back to our restorative doctor, which also happens to be Dr. Korsmo. I'm sad that he's not here today, but yeah, but you can appreciate that he did a very nice restoration, and seeing that really robust connective tissue graft underneath that flap made me very happy when I followed him up. This is a case that I actually did with my dear friend, Dr. Hannah Doan. And she was here, and then she actually shared the final photos with me when she delivered the restoration. So I was actually able to add that last minute. And this is our patient, Sandra. And when she came in, she had a fracture number 3 and failing number 8. And yes, she's had this crown for a long time. And this is the way her smile was. And her main goal was anything will look better than this. And you know, she was very, very sweet patient, but I wanted to do my best to improve that tissue level. When we took a CT scan here, she had you know, pretty extensive internal/external root resorption. And when we took the tooth out, there was a pretty significant fenestration and a lot of infection tissue, so I decided to just graft this area first. So we go ahead and do our bone grafting and do a flap, and you can still see there's a lot of soft tissue volume loss, and that's really where her bone level is. But I want you to focus first on bone augmentation. So this is her 4-month healing, and even though the tissue level has come down, there's still good amount of soft tissue crater. So at the time of 4 months, we go ahead and take a CT scan. We see nice bone healing. We're gonna go ahead and place the implant, and then we decide to throw in some connective tissue graft at the time of implant placement, and then get a nice primary closure. Now, in hindsight, I feel like I could have placed another graft just crustally. I just place it on the buccal. So you're gonna see how the healing looks like. And this is time after, 4 months after the bone grafting, tooth removal and bone grafting. And this is 4 months after implant placement and addition of connective tissue graft. So you can see the papilla area, we're still lacking some volume, but at the crest and buccal, we were able to get a little more soft tissue volume here. And we go ahead and deliver the provisional. And there's still good amount of black triangle, which we've already let the patient know that is not something that will improve with an implant or restoration. And this is 1 month post-provisional delivery. And you can see that that black triangle has actually gotten a little small. And again, in hindsight, I probably should have contoured the subcritical zone a little bit more. Maybe take the provisional out and add a little more concavity that might have brought the gingival margin more down and fill the papilla a little bit more. But the patient was very happy, so we send the patient back to Dr. Hannah Doan. And again, this was initial presentation, and this was time of provisional delivery. And this is time of final restoration. So Dr. Hannah just told me that she just replaced number 8 and she didn't replace number 9. I thought it was a really, really nice restorative work, and I'm sure Sandra is very, very ecstatic. We also use connective tissue graft after implant complications as well. So once we finish Le PIP, as most of you are very familiar with, we go ahead and do our final evaluation, and in this case, we still had this little soft tissue fenestration, so we decided to throw in a connective tissue graft. And you can see at about 3 months healing, that tissue now has that nice buccal thickness. Even though we still have threads exposed underneath that, now that tissue has a nice seal and it's protective. So connective tissue graft can also be utilized around implants after Le PIP. And this is Jordy recently. One of his favorite things to do is kind of throwing stuff. He throws balls, he throws rocks. And another thing he's working on is just trying to become a Korean b-boy. But what makes us the happiest is his little contagious laughter. I'm gonna see if we can play this. I wanted to make sure he can be here with us in spirit. And hopefully this kind of wakes everybody up a little. Okay, so we're gonna go ahead and change gears and talk about some teeth and recession. So what makes us choose between connective tissue graft versus free gingival graft? We go through different factors in determining which treatment is gonna be the best outcome for the patient. And the number one thing is really a goal of therapy. Are we attempting to have root coverage, or are we trying to gain more keratinized tissue? Is there a frenum in close proximity to that recession? Is there a shallow vestibule where we have to gain more vestibule to prevent further recession? Is it an aesthetic zone? Is the patient tissue biotype thin or thick? How much of keratinized tissue is remaining? And is there any interproximal bone loss that limits us from getting full root coverage or any root coverage? But the most important thing really is determining what's going to be the best long-term outcome for the patient, and that's how we decide whether the patient's going to receive connective tissue graft or free gingival graft. So let's talk a little bit about keratinized tissue. Keratinized tissue is defined as free gingiva plus attached gingiva. And what we care about the most is the amount of attached gingiva. Tissue can be keratinized, but if it's not attached, it's not protective. And attached gingiva is, again, it's a part of keratinized gingiva, and that's what's firmly connected to the underlying bone. And in a case like this, if there is at least 1 millimeter of attached gingiva until we hit the mucogingival junction, it is considered minimal attached gingiva. And in a case like this, when there is 0 millimeter of attached gingiva, now we have a mucogingival problem. So our goal of therapy changes in terms of gaining attached gingiva versus gaining root coverage. You guys probably have seen this slide many times in this study club. It's a Miller classification that periodontists love to talk about. Pretty much we use this classification to help us determine the predictability of having root coverage. And this classification uses interdental bone loss. After class 2, or starting class 2, we actually have a mucogingival involvement. But starting class 3, now we have interdental bone loss that results in partial root coverage, and gaining a full root coverage is not possible after that classification. And this is another classification that's also being very widely used. And it talks about, again, uses mucogingival junction as a reference point, and also helps us determine the predictability of root coverage. And recession type 2, it also discusses that there is interproximal bone loss, interproximal attachment loss, and that determines is a limiting factor in getting root coverage. Now, but not all roots are smooth, and not all recession types are smooth in nature. Actually, most of I would say about 50% of recession types we see have some sort of step in that cervical defect. Now, we see a lot of non-carrier cervical lesions, and in a lot of our correspondence reports, you guys will probably see this NCCL quite a bit. And non-carrier cervical lesions, as you all know, is any loss of tooth structure in the cervical area that's not caused by caries. And they're caused by many factors, like abrasion, erosion, effractions. Abrasion is really caused by aggressive toothbrushing or using abrasive toothpaste or toothpicks. They tend to be more saucer-shaped, and effraction defects are looking more wedge-shaped. And the theory behind it is the parafunctional habits cause cervical tooth loss. And the non-carrier cervical lesions causing tooth loss not only on the tooth surface and the root makes it really hard for us to determine where the true CEJ used to be, and that makes it harder for us to predict what the root coverage will look like. And sites with non-carrier cervical lesions that were only treated with grafts actually have higher chance of gingival recession recurrence. What that means is that we need to make sure we understand the etiology of why these recession defects happen in the first place. Is it their abrasive toothbrushing technique, or is it their clenching and grinding habits? So what we always tell patients is doing tissue graft is only repairing the damage, but we need to understand that they have to change the way they brush their teeth and be able to protect their teeth with night guard and other appliances. So Pini Prado came out with an article that actually classifies different types of root surface discrepancies. And in this article, what they talked about was whether there was a CEJ that was visible or if there was a step. And by step, what they defined that as was the horizontal depth is about 0.5 millimeters or higher, so it's pretty shallow. But what they wanted to show was using these 4 different classifications, the outcome of tissue graft predictability of having root coverage can change quite a bit, and the recommended treatment is also going to depend on that. This article from a Brazilian periodontology article actually uses Pini Prado classification and classify that into different categories and came up with recommended treatments. And most of them recommend using soft tissue grafting like connective tissue graft and or doing a restoration. And there are two classifications that they recommended actually doing restoration only without using tissue graft. And those are cases where we have a very, very deep step. So whether CJ is visible or not, if the step is like V-shaped and greater than 2 millimeters, and if the gingival recession isn't very large and it's not an aesthetic concern, they actually recommend doing a restoration only. Now in cases like this, in order to do a tissue graft and for that tissue graft to fill in 2 millimeters or greater, there's no guarantee that that's actually going to be a true attachment, and we would have to make a big bevel over here to have good tissue adaptation and good restoration adaptation. But if it's going to compromise a tooth structure too much by removing that bevel, it's actually better to place a restoration instead of doing a tissue graft. So in this case, we treated these 4 teeth, and each tooth had a different classification. Well, actually, this tooth only had visible CJ, no step, and these 3 teeth had no visible CJ and no step. So in cases like this, what this article talked about was when there is CJ visible and no step, you could actually just do a flap procedure where you release the flap and then just coronally move that up in cases of thick tissue biotype. But our patient in a previous slide had pretty thin biotype, so what we decided to do was do a connective tissue graft with a flap. And the other 3 posterior teeth that had no visible CJ and no step, those defects are usually shallow, but it does affect both crown and the root. And the recommended treatment would be either tissue graft only or adding a restoration on cervical, especially if there's hypersensitivity. So in this case, what we decided to do was have a flap exposed so I can go in and really finish the root surface nicely. So we go ahead and make our incision this way, and I'm going to go ahead and de-epithelialize these papilla. We go ahead and do a partial thickness flap and add a connective tissue. In this case, I actually did what we call de-epithelialized pharyngeal graft. I'm going to show you some cases using that technique, but I have been using this quite a lot, and it just the handling of that compared to using a subepithelial connective tissue, which essentially is the same thing, but how I harvest it is different, has really made a difference in my opinion. So we go ahead and finish our flap, we move that flap back up, coronally position it, and this is how the patient heals. And you can see there are still cervical lesions exposing dentin. And if these are causing patient hypersensitivity, we go ahead and have the restorative doc restore them. Otherwise, if they're not bothering the patient, it's okay to leave them. So,
Dr. Cha, do you need special root surface preparation?
Do I? No, I just use finishing burr to do that. Like in residency, we used to do like citric acid, tetracycline, and all that, but I don't think it makes any difference clinically, as long as you just plane that root really nicely, and there's no irregularities.
Question?
Yeah.
If there was a filling in there, you remove the filling?
Yeah, great question. Yeah, I have some cases coming up to answer that. So in this case, when patient presented to me, patient already had an existing filling on number 12. And the depth of this filling, I have no idea how deep that is. There was a little bit of staining around it, and the restorative doctor that referred the patient to me did not do this restoration, so I didn't want to ask the patient to remove that restoration to do the tissue graft. So what I decided to do was just modify that restoration. And tooth number 13, again, CJ was not visible, but there was a step, so that's a different classification that we're looking at. And if you take a look at this picture a little closely too, patients actually had a couple gum grafts done. These are pharyngeal graft. Doing this on the maxilla is not common, but the goal of therapy was to gain more keratinized tissue, and that is there. But what we wanted to do was create a little bit more aesthetic outcome around these premolars. So this is talking about tooth number 13, and our recommended treatment was doing restoration and no, sorry, this is actually talking about tooth number 12. I didn't know the depth of the restoration here, but my goal here was to kind of keep the restoration where it is to the level of CJ and just adapt the connective tissue apical to that. So in clinical setting, I go ahead and flap this case, very similar to the other case that I did. I go ahead and de-epithelialize my papilla, and this is how 13, now I go ahead and shape my root so it's nice and flat. And this CJ is now more prominent. And on number 12, I go ahead and remove the restoration to where I think we will get a root coverage. And we go ahead and lay our tissue graft. This is what subepithelial connective tissue looks like. There's a little more fatty tissue. I probably could have removed it. And we go ahead and do our flap, sutured back. And this is healing at 3 months. So now you can see number 13 has nice root coverage. Number 12 also has an existing filling that's been modified, and underneath it is patient's roots and strong connective tissue attachment. So yes, if there's an existing restoration like this, and with the referring doc, if they don't want to remove the restoration or modify it, I'll just leave the restoration as long as it's not carious and it's intact. I'll just kind of modify it to the level of CJ.
Dr. Cha,
Yeah.
can I maybe stand more underneath this thing? I think this is picking up a lot of feedback.
Here?
Like, yeah, just underneath that
Oh,
speaker.
yeah. Okay, and with this restoration case, number 22 had CEJ, visible CEJ, no step. It was nicely smooth, root structure exposed. Number 20 had an existing restoration, although really well done. The depth of it, I'm not sure. 19, we had visible CEJ and a very slight step. Same thing with 18. And with this case, before I did the tissue graft, I actually talked to my referring doc, and we decided to remove the existing restoration. Now, Dr. Chloe Myrick, where is she? Yeah, there she is. I forget, did you do the restoration? Oh, okay, it was existing. Got it, okay. And yeah, Dr. Chloe was nice enough to let me know that she can remove the restoration. She's actually done this for me before with another patient. And when patient came back, you can see that the CJ is now beautifully visible and the root surface is really nice and clean. And so she did the hard work for me already. The patient came back to my chair, and we decided to go ahead and do our connective tissue graft. In this case, what I decided to do was do connective tissue graft on posterior teeth and do a phrygian graft on the canine. This tissue there was minimal keratinized tissue, but it was not attached, and I wanted to gain a little more attached keratinized tissue around that canine. So again, when patient came back, restoration was nicely removed. And I go ahead and place my phrygian graft and connective tissue graft. And patient came back in 3 months. And this was an RT1 case, right? There was no interdental attachment loss, and patient had really nice bone, interdental bone, and nice papilla. So we were able to gain full root coverage. This case, I decided to use de-epithelialized phrygian graft. So essentially what I do is just make a little outline of how long my graft is going to be. And I take this little flat diamond burr to just remove the epithelium, about like 0.5 millimeters. And we take that tissue and we lay it on, in this case, I laid it underneath that flap. Here I created what we call a vista incision. It's just a small incision we make in the mucosa, and then we're gonna go ahead and tunnel coronally, and we need to make sure we tunnel adjacent teeth to have that really nice passive tunnel. Then we go ahead and place that tissue graft, secure it, and the healing is actually pretty minimally invasive for the patient. And all we have to do is just close that little vista incision that we placed. And at 3 months, again, another RT1 case, so we were able to get a nice root coverage. And this is one of the cases that I actually inherited when I first joined PSP. And she's already had upper tissue graft done, and she was no stranger to using autogenous tissue. She actually had full autogenous tissue graft done on the maxillary arch using a Vista technique by another periodontist. And when I met her, her healing was looking really, really beautiful. And she was expecting the same results for the lower. And you can see that she's actually previously had gingival graft done completed on the lower anterior. And she has some combination of non-carrier cervical lesions, but just pretty much recession everywhere on the mandibular arch with very thin periodontal phenotype. So with this case, what I wanted to do was do a de-epithelialized gingival graft, because the handling of that is just so much easier, and harvesting that, I'm able to harvest a lot more than doing a subepithelial connective tissue graft. So I go ahead and do my tunnel. In this case, there was no incision made. We just make incision around teeth and go ahead and tunnel the whole arch. By doing this, I'm trying to preserve blood supply as much as possible. And we go ahead and feed the graft through canines. And on the next slide, you're actually going to see the shape of the graft, which might not look very aesthetic, but just seeing that the tissue has positioned and stabilized so well, I really liked seeing how her healing was coming along. So this is at 3 months. You can almost see that we have one segment of tissue graft here, one segment here, and a third segment here. And this is at 6 months. And some of the cervical lesions, again, we were able to get root coverage up to CJ, and the restorative doc restored one premolar cervical lesion, but the rest of them didn't bother the patient, so we left them as they were. And tunnel technique, I often also use this in lingual CTG cases. So again, it's showing the process of how I do gingival graft de-epithelialization. So make my incision and go ahead and use this burr to remove the epithelium. I go ahead and harvest this just like I harvest gingival graft. And this tissue is just so much easier to maneuver. We go ahead and feed that graft underneath the tunnel. And for lingual CTGs, I like to keep my knots, suture knots on the buccal. So it really helps the patient not play with them around the graft site. And at 3 months, again, this healing is really not very painful for the patient because we went through the tunnel process and there isn't much swelling involved with it. And around non-carrier cervical lesions, gingival grafts can also be used. So with this patient, I actually had back in California, number 28 had very severe mucogingival defect, and surprisingly, patient had no sensitivity around these teeth, and he just didn't like the look of how the tissue looked like. And once we educated the patient about the need for the tissue graft and possibly the restoration, he was willing to go through the tissue graft. So here, what we ended up doing was place a very large gingival graft. I had no idea where the CJ was, so I'm hoping that the tissue graft will kind of stabilize itself and help me determine where they are. And when it healed, we were able to get really nice stabilization of the tissue, gain some root coverage. This probably isn't where the CJ is, but considering the tooth position and how much dehiscence there was, we're really happy to see he was able to get nice tissue protection. And my referring doc at that time decided to do cervical restorations done really nicely. So now going from here to here by using gingival graft, I was really happy to see the transformation with using patient's own tissue. So again, tissue graft will bind to root surfaces only, and the cervical restorations often will have to be restored by referring docs once you guys decide to. But I always have that discussion with the patient that we may have to do another restoration after the tissue graft has been completed. So with this case, when I had this case referred to me, there was very beautifully done 2 restorations, class 5 restorations on tooth number 20 and 21, but we had very thin tissue underneath it, and what we wanted to do was really augment that keratinized tissue for nice phenotype. And what I wanted to do was kind of improve the look of these two roots. And even though they're posterior teeth, that was bothering the patient, how low these teeth were. And these restorations were very intact, well done. So I went ahead and did a pretty minimal modification of the restorations and placed my pharyngeal graft. And this is how it healed. We're able to keep the restorations in a nice condition and still be able to gain keratinized tissue now that's robust and stable. And this is one of my cases, I think possibly was already shown by our hygienist, Chad. So if you were here, I'm going to be talking about the same thing. And this was a very young patient that I saw, and he was hoping to go through ortho, but he wasn't quite ready. So he wanted to just make sure that he's ready to move forward when he is. So without knowing the ortho plan or what teeth will come out and whatnot, what we wanted to do was just improve his gingival recession and his tissue condition here. So what I decided to do was a long pharyngeal graft around these 3 teeth. And this is how it healed at 3 months. Tooth number 23 was very buccally positioned, so considering that, we were able to gain nice root coverage and keratinized tissue. Tooth number 21 still had about the same amount of recession present, but gained a lot of keratinized tissue. 22, I would say, had about maybe 25% of root coverage, very little keratinized tissue gained apical to that. So I was not happy with how 22 ended up, and I suggested that we go ahead and do another procedure to improve the healing. And what we decided to do was laterally positioned flap. And this is when we use the adjacent keratinized tissue to move it over to get more root coverage. And the incision looks something like this. We go ahead and make an incision mesial to where the recession defect is, and we go ahead and de-epithelialize that. And the tissue that is going to be moving over to the root, you want to make sure this is obviously wider than the recession defect, but even wider than that to be able to cover recession defect and the area around it for its blood supply. And these types of grafts are called, or flaps are called pedicle graft because the blood supply is still connected to the flap. So we don't have to take another tissue, take another graft from the root. We can just utilize what patient has and improve that condition. So once we make that other incision here, we go split thickness, and we want to go a little periosteal release. So now this tissue can move passively, and move that tissue over, do suture, and this area right here is going to heal as secondary intention.
How long do you wait to do the second graft between after the first graft has healed? How long do you wait to do the second graft?
You can wait as short as 3 months. So we usually typically see patients at 3 weeks for suture removal, around 3 months or so. But there are cases that I waited even longer, because some cases I'm hoping to see that creeping attachment, right? And with this patient, I saw him at 3 months, and when I saw that robust keratinized tissue next to it, I was like, we can just use this. It's going to be a simple pedicle graft. So to him, I suggest doing it at 3 months. But I'm going to show another case that I waited years to do a second procedure. Yeah. And this is how it healed after the second procedure at 3 months. We still have nice keratinized tissue from that new donor site, and now we're able to gain really nice root coverage on tooth number 22. And we're heading towards our very last case, and this is a case that I was just talking about. When this patient actually had seen a different periodontist right before me, and this was her initial presentation. So you can see that patient was trying to have orthotherapy, and patient came in for ortho clearance. And what the periodontist decided to do was really just improve that tissue type. But having that root coverage was going to be very challenging or almost impossible because this tooth is super erupted. So what the provider decided to do was just add a nice thickness by doing connective tissue graft underneath it. And when I met the patient, this was probably almost a year and a half over since that tissue graft was done. And when I saw this picture in some documentation, she mentioned that she thought she split her gums open while using water pick on that tooth number 24. And she was almost done with her Invisalign treatment. So the provider decided to do a second procedure of connective tissue graft. And that was completed here. And when I met the patient for the first time, it was about 3 weeks after the second connective tissue graft was done. And you can see the root coverage is not great, and the tissue is still looking quite non-keratinized to me, but we wanted to let the healing finish, wait about 3 months. And this is how she presented at 3 months. And when I saw this, I wanted to kind of improve that tissue biotype, maybe remove that frenum, and hopefully get some root coverage. So we decided to do a pharyngeal graft here. Remove the frenum, and this is how she came back at 3 months. And now I felt horrible because I feel like this was her third graft and I made it look even worse. Seeing that keratinized tissue adjacent to that site, I was happy with, but there was even more root showing. Patient didn't have any sensitivity to temperature, but she was definitely not happy with how the healing looked like. Now here, I didn't have enough tissue laterally to try that pedicle graft. So what I suggested to the patient was, hey, you've already had 3 gum grafts done. Why don't we go ahead and give it some time to heal up? See if there's any creeping attachment in a year. So I see her in about a year, looks about the same. I see her in another year, looks about the same. And now I'm like, okay, we need to do something about this. We're losing even that thin amount of keratinized tissue. So I go ahead and refer her to Dr. White. Dr. White came to rescue, and he completed orthotherapy for her. And what he did was kind of putting this tooth number 24 lingually, and kind of putting that tooth a little bit more into the bony housing. And he placed this little nice lingual wire for us as well, so that there's no more shifting. And with this in place, I wanted to go ahead and do our 4th gum graft. She's a trooper. So we went through our 4th gum graft, and now really just crossing my fingers. And she comes back at 3-week healing, and it's looking very promising. And this is at 3 months. So going from that 3rd tissue graft and not so optimal healing to having 2nd ortho done and 4th tissue graft done, we were finally able to achieve more optimal healing. Although it's not perfect, I just wanted to kind of share this case to show that not all tissue grafts go smooth, and sometimes we have to have multiple procedures and involve multiple providers to get the tooth into position and have the best outcome. So with that being said, on behalf of all the doctors at Puget Sound Perio, I thank you everybody for coming here tonight and spending Thursday evening with us. We're trying to work on getting Dr. Nordley a new headshot. Thank you very much.
So I just want to add, if like me, you want Jenna to see all your patients now. We 2 things. One, in the last 2 years, Dr. Stern and Dr. Zahedi have moved on, and we've added Dr. Shamoon and Dr. Nordley in their place. And so we do have updated referral pads. If you don't have one of the updated ones, and Tony's great about making sure that those are dropped off, if you don't have updated ones, please recycle the old one, let us know, let us get you the new one. And then our office is really good in the sense that even though there's multiple doctors, you can have your periodontist. And if you want Jen to be your periodontist, please just mark that, and our team knows to make sure that she's seeing your patients. And I wouldn't blame you. That's a phenomenal presentation. Thanks, Jenna. Thank you, guys.
Thank you. Any questions?
All right, thank you, everybody.
All right, great.
As always, make sure you fill out the roster so that I can get you your CE credits. Our next event is going to be Thursday, the 18th next month. It is going to be a little bit more hygiene focused, so please ask your hygienist to come to that event. If you can shoot me I'll be sending you out your CE credits. If you can shoot me an email address for the hygienist or let them know, pass on the event, that would be great. I'll be collecting RSVPs for those at the beginning of September here.
Your hygienists are all invited to all these as well, by the way.
Yep. All right, thank you all so much. Appreciate it. Thanks for bearing with us. We're going to wait on there.
Good job, Killer.
Thank you. Oh, I feel like I talked so much. Was that an hour?
Yeah, because we got started at, I think, 7:50.
okay.
So you're like,
Okay. Okay, good.
well done.
Thank you. I'm done. Get to eat. 안녕하세요. 오셨어요.
Awesome.
감사합니다. 아, 바쁜데 와주시고. 네.
다행히 와야 돼. 잘 있어.
네, 네, 잘 있었어요. 네.
Thank you for taking care of
네.
my issues. Patients. Oh, there's one patient. She has an implant that has a separation. I think one of this. And she's scheduled out. So I saw her today. She had a
Oh, yeah.
yeah. So she
Yeah, she called.
So I encouraged her to use this.
Yeah, she called and she's coming on Monday now. Yeah, we moved her up.
So I said, how dare you? I don't have a whole lot. I told her, how dare you? She went out that late. Yeah, so looking at the case, would she be in the future, I don't know, maybe graft that area as well?
Tissue graft? Yeah, probably. I prepped her for it. Yeah, like when there's so
I'll
much.
encourage her.
Yeah, then when there's so much swelling, you're gonna lose all that tissue, and it's not gonna come back. Like the case that I showed, tissue was still there, but I've had cases where tissue goes down and threads are showing. But she's probably gonna look like that because there was no bone on the buccal. So, but if we have good healing, tissue can still stay, but it'll be really thin. So I'll still add some gum graft, just make it thick.
Encourage her. We've been trying to encourage her hygiene.
Yeah. Yeah.
Thank you.
Oh no, thank you for sending her.
Yeah, I don't know. I have to utilize however long we're gonna. Is it gonna be like October?
Baby? Oh, December.
December. So are you staying until
I'm taking 3 months off, and then I'll be back in March.
starting December? You'll be off?
I'm taking 3 months of maternity leave.
Right.
Yeah.
So when does it start?
Oh, December.
Oh, December.
Yeah, so December, January, February, and then I'll be back in March. Still try to do 3 days. We'll see what happens. Like our daycare doesn't accept kids over or under 1. So I don't know what we're gonna do with our second one. I think I have to find a nanny. Yeah, so it's gonna be a process.
Family's out there.
Yeah, well, my mother-in-law helped with my first, but she only had to watch him twice a week, but she has to watch this girl 3 times a week, and we feel bad. She lives in Bellevue. She got to drive all the way down. You're gonna ask tell my husband. Yeah, he's here. I don't know where he went. Oh yeah, he's here. I want to introduce you. Yeah.
Is he working?
Oh yeah, he's a dentist.
Right.
Oh,
But is he still working at the same place?
With Randy Olson. Yeah. So that's a lot in the air, but I definitely want to come back to work because I don't like staying home with kids.
My wife probably go. Every opportunity she wants to get out.
Yeah, you have 2 sons, right? Yeah. Oh, man, that's handful.
Kudos for your husband because he'll love the dog.
Yeah.
Good job.
Thank you. I feel like I didn't look at anybody. I was just like glued to the monitor, but I don't know how to like.
You're avoiding bag.
Yeah. Oh, good. Yeah, I feel like I was talking really fast because it was already so late. But oh, that's good. That's good. Thank you. 저 남편하고 인사 좀 드리고. Yeah, right in the middle. Hey, Brendan, I wanted you to meet Dr. Hong. He works in Normandy Park.
Oh, really?
Yeah.
Oh, awesome.
Yeah.
Okay.
Thank you so much. Thank you so much. Thanks, Zoe.
Wow, that's
Talk to
very
you
close
soon.
to where I work.
Yeah.
I'm just an associate at my office.
And Dr. Hong, I don't know if you met my colleague Kevin. Oh yeah.
Good to see you. Thank you for coming.
Yeah. So like we had dinner once, and then ever since then we've been working really closely. Yeah. So he's one of my very good doctors that I work with.
Oh,
Yeah.
awesome.
Yeah.
Okay.
Yeah, so we'll have to visit someday. So come. Jen, she'll tell you where I am.
Yeah. Really nice
Get ready.
location, Normandy Park.
What was that?
Oh, congratulations.
Oh, thank you so much. Yeah. It's been a wild ride.
Yeah.
So 3 little girls along where we are eating to, and we're constantly looking at
Yeah. 3.
love.
Yeah.
Having 2 boys is great, but boys are boys.
Yeah.
They play differently, they feel differently.
Oh.
Jenna wanted a girl really bad. But then that's why.
He did too.
No, that's why I thought she was gonna have a boy. We're gonna have a boy. For sure, we thought it was gonna be a boy.
It's like
Turned
always the
out
opposite.
Yeah, oh my gosh. I was so relieved. Thank you.
Because we wanted a girl for ours. And they'll go, are you sure? There's a keeper.
2 boys and done.
So, should we have another one? I said, no, there's no chance.
Oh, she wanted to try another? Oh, you wanted to.
There's no guarantee, no way.
Yeah, exactly.
Yes.
I see all the families with 3 sons. I was like, I know what happened to that family.
Exactly.
Yes.
Yeah, well, come by. Now that she's gonna get home, maybe you can come. Or maybe you want to rush.
Sorry, I'm sorry. Thank you so much.
Thank you so much for coming.
Listen.
Thank you.
And all the best to you as well. Very nice to meet you. Yeah. Good luck. Yeah. Oh, thank you.
Come by. Obviously, I'm very close. First Avenue.
Okay.
Right? Yeah. If you see Normandy city sign, that's
Do you know Randy Olson?
you know, I'm kind of in cocoon, so I really don't know a whole lot of people. Even people that I knew.
Okay.
I kind of got used to it.
Yeah.
Retiring. Maybe it's like
Yeah, my dad too. My dad works here in Federal. He's a dentist too.
yeah, right.
Yeah.
He's still going strong.
I don't know about strong. Maybe not.
He's strong. Yeah. He's still young.
Yeah, he's looking okay.
Yeah.
But he's kind of has an attitude where he's like, if I retired, then I retired.
Yeah.
Like time was gonna tell me.
Yeah.
We'll see what that means. I hear people change their opinions in their 60s.
Are you still working by yourself?
Yeah, I'm gonna look.
Look for an associate? Yeah, you should, because it's hard working by yourself. You gotta enjoy your time with your boys.
How old are your sons?
12 and 10.
12 and 10. Oh, they're gonna be teenagers. Oh man.
It's already back.
Young men.
Oh my God.
Young men are
Bye, Dr. Thank you.
So enjoy your time.
Yeah.
We used to take lots of pictures like that.
Yeah.
Years ago, but
Yeah.
now we're looking back. We still do. It's like,
Yeah. Oh, man.
yeah, we love to chat and combine all this.
Okay. Yeah, absolutely.
No pressure.
No, definitely. We should.
Yeah.
Sometime.
Yeah.
You're so close by.
Yeah, and his sister's also a dentist. His sister's also a dentist. Yeah, so maybe,
Family.
yeah, maybe she can work for you.
Oh, maybe?
Yeah,
She around the area.
Yeah.
she lives in Bellevue with the
Like
parents.
Renton, like Newcastle area. So, yeah, she's actually maybe looking for a job. So, she's kind of moving around some practices. But,
Yeah, I
if
feel
you're
like
looking for an
she's always
associate,
looking
maybe-
for a better opportunity. Yeah.
Yeah, if you ever want to be an associate, maybe my sister might be able to help.
I am.
With no pressure.
Hi, thanks meeting you. Thanks for coming, Steph. We'll talk soon. Yeah. 오케이, 가세요. 감사합니다. Hey, I'm glad you made it. Thank you. I'm glad you made it. Thank you. Oh my god. I felt like I didn't look at anybody. I was just like avoiding eye contact. Just finish.
No, you did so good.
Thank
I like
you.
the content.
that's
I
good.
actually learned a lot about. I mean, I didn't even know about the whole classification of those cervical lesions.
Well, I didn't either. I learned it last minute. Like, what can I put in the PowerPoint?
No, that was. I mean, I didn't know that you.
Dude, I mean,
took those kind of things into account to decide what to do. I just.
Yeah, I mean, they have classifications for everything.
Yeah, fair.
But obviously we don't use them.
Right,
Yeah.
right.
But yeah.
It helps to drive and figure out what to do, which is nice because.
Yeah.
I don't know. I feel like I was doing composites on stuff at one point, and then
That's
when
fine.
I talked to you
Yeah.
that one time, we went to dinner or whatever, and I feel like you swayed me the other way, kind of, unless you're having symptoms.
Yeah.
Yeah. So now I'm like,
Yeah.
okay, now I know a little bit more.
Yeah. Well, I'm glad you made it.
Thanks.
Aw, thanks for
it was
coming.
good to see you speak. Absolutely.
Thank you.
Yeah, you got a good turnout.
I'm so glad I'm done. Yeah, I know. I got a really good turnout. Yeah.
Do you guys each have to do one, or is it
Yeah,
required
kind of
to
encouraged. Yeah.
That's fair. Sometimes it's kind of hard to find a topic, I feel like.
Yeah, because like, yeah, and actually I was supposed to do one last year, but hey, thank you.
Lecture.
Thank you so much.
I was literally just wondering some of the questions that you like answered in there. So
Oh,
like
good.
that was like really well timed for me.
Well, I didn't give anybody to ask questions. I was just like,
You're like,
don't look at
I
me.
never want questions. I literally am always like, don't ask questions. I don't want to
Yeah.
answer them. Yeah, I get it.
Yeah.
Good job. You did a good job.
Thank you so much. Yeah, no, but it was like really cool to see a lot of women in the audience. Like that's what I was like telling my friend earlier. And I was like, wow, I feel really empowered to see so much women.
So cool. I know,
You know?
being up there pregnant and like having a
Oh.
cool combo. So good for you.
Yeah, so it was really great.
It feels the same. It's kind of nice.
Yeah, thank you.
Are you only down in this area? Or are you practicing in?
No, I'm just in Federal Way
That
now.
makes sense.
Yeah.
No, I'm just here to
Yeah.
socialize. I'm still only in Cap Hill, but
Well, Capitol's a nice
Capitol's really
area.
nice.
Yeah. You live up there too?
no, I live in Wallingford. I'm actually in the same building as Amanda, so pretty close by.
Oh, okay. Wellingford.
Close to
Like
Capitol.
Green Lake area.
Oh, okay. I only thought of Green Lake. Oh, okay.
Yeah. Oh, yeah. It's like no one really.
It's called Wellingford?
Wallingford. It's. I mean, I don't think that a lot of people know it if they're not.
I see.
in the area. It's like the Green Lake is more known. It's
Yeah.
right near Green Lake.
Oh, okay.
Yeah.
Okay. Yeah, nice area.
I
Yeah.
gotta drive back up there though now.
I know.
It'll be fun.
Yeah, I know it's so late already.
No, it's okay.
Yeah, we started
And
late.
It could be worse.
Yeah, it could be worse. At least it's like still kind of